All right, guys. So I think we're going to get started. I know there's still a lot of people to trickle in, but we just have so much to get through, so I just don't want to lose some time here. So there are still many faces in the audience who I have not had the pleasure of meeting yet. So to introduce myself, my name is Fruchter. I'm one of the current CCF. Louder. Is that better? Okay. So many of you I hadn't had the pleasure of meeting yet. So to introduce myself, my name is Fruchter, and I'm one of the current CCFP EM residents. And I have been given the challenge of today's grand rounds. So today's talk is maybe a little bit different than what we're used to. We're going to stray away from the excitement of the trauma bay and the recess room and wander over in our minds to the urgent care setting. And although this may be slightly less exciting at times, it certainly can still pose an incredible challenge for us. Is this better over here? Yeah. Okay. I think part of this challenge comes from the fact that there's a huge variation in how we all approach the same clinical presentations. And it can sometimes leave us wondering whether or not we've made the right decision for our patient once we left the ED that evening. I think part of what really drives this challenge is the fact that there's often a lack of evidence to help guide us. So the purpose of today's talk is hopefully our goal will be to review the evidence behind three common urgent care presentations that either have evolving management strategies or controversial management strategies, and that will be corneal abrasions, distal phalanx injuries, and epistaxis. And it's certainly not meant to be a comprehensive review of all three of these entities, but simply we're going to hone into specific aspects of their care. Now, I will be the first person to admit that a lot of the evidence we talk about today may leave something to be desired in terms of methodologic quality, sample size, and publishing date. But the fact of the matter is that this is what exists in the literature for us to use. Some of you may find a pearl or two tucked in here, and some of you may not. But if nothing else, I hope that it just sheds some light on the type of evidence and studies that can continue to drive our teaching and management practices for years to come, whether they're good, bad, ugly, or excellent studies. So I have nothing to disclose. Nobody's paying me, although I wish I had shares in tranexamic acid. All right, so we'll start with a quick show of hands. How many people here are routinely prescribing topical antibiotics for corneal abrasion patients? And we'll start first in the non-contact lens wearer. So maybe about a quarter. And how about in the contact lens wearer? About half. Okay. For pain management in these patients, who's prescribing topical anti-inflammatories like diclofenac, topical Prophylactic? Okay, maybe 3-4 hands. How about topical cycloplegics like hematropine or cyclopentolate? 2-3. And is anyone a rule breaker and sending the patient home with topical anesthetics? Look at those proud hands. 10, 12 people. Awesome. Okay. So there's huge variation in how we all manage this clinical presentation, and the fact of the matter is that this lack of consensus among us is not new. Our very own Dr. Lisa Calder and Dr. Ian Steele actually published a report in 2004 in CGEM looking at the wide variety of management in corneal abrasion patients. So they surveyed 470 CAPE physicians, and this table here summarizes the percentage of respondents utilizing each of these modalities. In the report, they also talk about the huge variation amongst ophthalmologists. And when I spoke to one of our local ophthalmologists, Dr. Mike O'Connor here, and told him that corneal abrasions would be included in the controversial talk, he laughed because he said it is a constant source of frustration for them upstairs seeing each other's corneal abrasion patients in follow-up because they all do something different and the patients are totally confused. So what does the literature look like? Well, I can tell you first of all that it looks nothing like this stack of papers because only a single RCT has ever been conducted and 2 observational studies followed. So it was actually Kruger et al. In 1990 who first questioned the utility of topical antibiotics in the use of corneal abrasions. And they took 94 patients presenting to the ED with corneal defects confirmed by slit lamp examination and randomized them to receive either 3 days of topical antibiotics or saline. Important exclusions, they excluded all contact lens wearers, and important inclusions, about 54% of their patients had a foreign body removed at the time of presentation. They had follow-up slit lamp examination by ophthalmology, and they found absolutely no difference in infection rates, corneal healing, visual acuity, or persistence of symptoms. A couple of years later, in Kingston, Ontario, just down the road, Dr. King and his colleagues ran a larger observational studies of 351 patients who presented to their department with a corneal abrasion confirmed by slit lamp. This was a time when patching was a lot more popular, so everybody got a patch. Some people got cycloplegics, but nobody got topical antibiotics or oral antibiotics. And again, they were followed up by ophthalmology, by slit lamp exam, and they looked for signs of infectious corneal ulceration. And about 2 patients in the entire study developed small infectious corneal ulcers that were easily treated with topical antibiotics. So the infection rate was less than 1%, 0.7%. The last study published in the literature about this is a study that's done in rural Nepal, and it's actually the only study that promotes the use of topical antibiotics in corneal abrasion patients. And it's done in a population that the authors acknowledge have a 7 times higher rate of infectious corneal ulcer than North Americans. So they took all patients with corneal abrasions and they gave them all topical antibiotics. What they instead looked at was the delay in timing of presentation, and they found that patients who presented after 18 to 24 hours were more likely to develop infection. And what they concluded was that not only are antibiotics key, but early administration is also essential. So I think when you look at this study and you also consider the natural healing of a corneal abrasion, you can see some flaws with drawing that kind of conclusion. So overall, there's not a great deal of evidence to help guide us here, but there's certainly some suggestion in the literature that topical antibiotics may offer little benefit to the contact lens wearer. To the non-contact lens wearer. The exception to that is the contact lens wearer, and all of the studies that demonstrated safety omitted these people. And the reason is because they actually have very high rates of Pseudomonas colonization, and often their first presentation of bacterial keratitis is a corneal abrasion. So I think ongoing use of fluoroquinolones or pseudomonal coverage in this group is essential. All right, so if our topical antibiotics are potentially not doing too much for these patients, then arguably the most important thing that we can do is manage their pain. So judging by the show of hands, I would say that probably topical anti-inflammatories were a bit more, we'll say, popular in the early 2000s. So in Dr. Calder and Dr. Steele's survey, about 52% of CAPE respondents were utilizing this at that time. And there is quite a bit of literature to support their use. They're all small but positive RCTs. The problem with them is that there's a huge degree of variation in how they measure their outcomes. So some use verbal analog scales of patient-reported pain, some use visual analog scales, some use surrogate markers such as the need for breakthrough oral analgesics. But what's made it particularly difficult for people to pool the results is that they've taken these pain scores at different intervals at time, so 24 hours versus 15 minutes of administration. So it's very hard to sort of gather the small sample size studies. Nonetheless, there was a Cochrane review published on this in just May of this year, and they found a total of 9 RCTs looking at this issue for an N of 637. Now, they had hoped to measure a primary outcome of a pain reduction of 30 to 50% at 24 hours, but none of the studies actually included this as a primary outcome. So instead what they did was they pulled the results of 4 of the RCTs that utilized an outcome of the need for oral breakthrough analgesia above the topical NSAIDs. And they did find a statistically significant reduction in this with a risk ratio of about 0.46. It did have fairly tight confidence intervals. But overall, they felt that the quality of evidence was pretty limited, and they felt that there was unclear to very high degree of bias in the studies that existed, and as such, they felt that there wasn't enough evidence to support their use in the management of corneal abrasions. Now, just a couple of months prior to them publishing this, another group in Florida did kind of a shortcut review of the literature, and prior to that, it was Dr. Lisa Calder who published a systematic review and meta-analysis back in 2005. And both of these clinician groups, they acknowledged the limitations in the literature, but they ultimately felt that there was enough evidence to support their use. Now, I think what was interesting for me to read all 3 of these reports is that no RCTs have been done since 2001, since even before Dr. Calder's report. So all 3 of these physician groups have looked at the existing evidence and have drawn different conclusions. So I think when you pair that with the fact that many of the RCTs are quite small and may have methodologic limitations, as well as the cost of a single bottle of ketorolac being about $40 to $60 per bottle as per a local pharmacy, it makes it really hard to promote this as a first-line agent in the management of corneal abrasion pain. So personally for me, after having reviewed that, I think I'm unlikely to prescribe this to future patients. So what about cycloplegics? So both Tintinelli and Rosens recommend the use of topical cycloplegics in all corneal abrasion patients. And the proposed mechanism through which it works is that it will reduce ciliary spasm. And it is possible to get some mild anterior inflammation, anterior chamber inflammation after a corneal abrasion about 12 to 24 hours later. But it's never been published that this is ciliary spasm is a significant contributor to pain in this disease process. So despite these recommendations in the textbooks, there's actually only ever been one RCT published, and it was a negative trial in 2011. So Meek et al. Randomized a convenient sample of 40 patients to receive either 5% hematropine or placebo, and they took visual analog scale measurements at 0, 6, 12, and 18 hours, and they found absolutely no difference in pain ratings at any point in time. Since this study has been published, hematropine has actually been removed from the market, and I think why it was commonly used was you could apply it at the timing of the examination. It would last about 2 days, which was sort of how long the corneal abrasion would last. But now we're left with things like cyclopentolate, which is Q4 to 6 hour dosing, or atropine, which can last up to weeks in some patients. So again, I think with the very limited evidence that exists, not another entity that I would likely be sending my patients home with. So what about topical anesthetics? I think this is the one that probably everybody is most interested in hearing about. I think we've all had that patient experience where you have somebody sitting in the eye room, they're so uncomfortable, you put a couple of drops in their eye, and within seconds they're just saying, thank you, doc, that feels so much better. But a few of you were looking at me like I had 3 heads up here when I asked if you were sending patients home with topical anesthetics, and I presume that's because you're having flashbacks of preceptors who looked something like this when they told you that you should never, ever, 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 ever send patients home with topical anesthetics. So what's driving this theory? So I think probably many of you have heard that this has had considerable attention in the foam med world over the last couple of years, and a lot of those physicians feel that the evidence driving this comes from very scant case series and case reports and animal toxicity studies. And when one sits down to read the primary literature, I can tell you that this becomes very quickly true, apparently true. The vast majority, if not all, and I truly mean if not all of the cases and reports are case reports and case series of patients who have used buckets and buckets of tetracaine for weeks on end. Oftentimes they are high-dose, not just tetracaine, anesthetics. Oftentimes they are high-dose anesthetics, like 5% tetracaine. In many of the cases, they've started this medication without even having a medical evaluation because topical anesthetics are available over the counter in many parts of the world. And lastly, the animal studies are done in a species, the rabbit, who is known to have a sensitive cornea. And in many of those cases, they've actually done intraocular injections of anesthetics as opposed to topical application. So I've decided to just read to you a single case report, perhaps two, just because I really think it drives home the point of this. So in the first one, a 35-year-old gentleman is prescribed 5% tetracaine by his ophthalmologist, as well as tetracaine ointment for pain relief after pterygium removal. He uses it as often as hourly for the next 3 to 4 weeks. When he's seen back, he has reduced visual acuity to 1 foot to finger counting at 1 foot. In the second case, there's a 40-year-old gentleman with a fingernail abrasion who receives propylactic from a local ED and uses it as often as every 20 minutes for the next 2 months. So we all know where that one went. I think you read these cases and you think, well, surely this must be an extreme example. There must be better reports, better case reports driving this theory, but I have to tell you, they only get worse. So is there any evidence that's opposing this? Well, in fact, there is. There exists literature in both the ophthalmology world as well as the ED world. And I will admit they are small studies, but they certainly offer, I think, better methodologic, like a hierarchy of methodology than the case reports and case series that exist. In the ophtho literature, what they're being used for mainly is for post-op patients after a procedure called photorefractive keratectomy. And this is a procedure where there's a surgically induced defect in the cornea. And although it's not exactly the same as a corneal abrasion, these sterile lesions are very functionally similar. So let's have a quick look at the evidence. It's not new. It dates back to 1995, actually. Verma et al. Were the first to randomize a total of 44 post-photorefractive keratectomy patients to receive either 1% tetracaine or placebo for a total of 24 hours. The reduction in visual analog scales was, I think, minus 7.5 in the tetracaine group versus 3.5 in the placebo group. And all patients had follow-up slit lamp examination at 72 hours by ophthalmology, and there was no persistent fluorescein defect in any of them. They all had full corneal epithelial closure. A couple years later, another group of physicians got a little bit more bold with their recipe. They randomized a total of 44 post-PRK patients, and this time they gave them propylactic 0.05%. And they told them they could use it as often as they wanted for a total of a week. Now, I admit even that's a little too long for me. But again, they found significant reduction in pain compared to placebo and equal time in corneal healing on slit lamp examination by ophthalmology. So what about in our world? How about in the ED world? So Ball and al. Were the first to actually look at topical anesthetic provision to corneal abrasion patients, and they took the similar recipe as this last study we talked about. So they randomized 33 simple corneal abrasion patients to receive either proparacaine at 0.05%. They were told they could use 2 to 4 drops as often as they wanted for a total of 7 days, and the other half was randomized to placebo. They gave the patients a total of 40 mils, which again I think is an incredibly large amount. But in any case, they had follow-up slit lamp exam at days 1, 3, 5, and 7 with ophthalmology, and there was no change or difference in corneal healing between the two groups. And the visual analog scale pain reduction was minus 3.9 in the proparacaine group versus 0.6 in the placebo group. The largest study to date is by Waldman in 2014 and his colleagues. So 116 patients. This time, I think, probably a more realistic recipe. 1% tetracaine every 30 minutes for a total of 24 hours only. 1.5 mils was prescribed to the patients versus placebo. They measured pain scores once at 24 hours, and interestingly, this was after the meds had been used, and they found no difference. But when they asked patients about their perceived effectiveness of the drug, the tetracaine group rated the effectiveness at a 7.7, and the placebo group rated the effectiveness at a 3. So I think probably in the way that they asked the question may have come into play there. Most importantly, though, was that there was no complications seen, and there was absolutely no difference in epithelial healing at 48 hours on slit lamp exam conducted by ophthalmology. So since this study was published, a group of ED physicians at their institution actually adopted this practice, and probably about half and half, but they have made up kits of 1.5 mil of 1% tetracaine that they give to patients when they leave. And they did a retrospective chart review to see how that had been going for the last 3 years. So they found 303 patients that had come through their ED that went home with 1% tetracaine with simple corneal abrasions. And they compared them to standard treatment, so all of the ED physicians who weren't prescribing. And they looked at the rate of ED rechecks, the number of ophtho referrals, and the number of complications. And they found no difference in the standard treatment versus the tetracaine group, and they also found no complications. But what they did find was that there was a number of patients who didn't actually meet their definition for simple corneal abrasion who ended up getting tetracaine. Now, in a lot of cases, this was, maybe the patient didn't meet the age criteria. So they'd set an age criteria of 18, the patient was 17. But in some cases, there was patients with retained rest rings. There was at least one patient with herpetic keratitis and 3 patients with recurrent corneal ulcerations. Now, these patients did have a higher rate of ED rechecks and ophtho referrals, but none of them had any long-term complications related to tetracaine. And I think, or any complications period related to tetracaine. The increased number of ED rechecks and referral likely is from the difference in the underlying etiology as opposed to tetracaine. But it is definitely interesting to note and really drives home the point of doing a good examination and making sure you have your diagnosis correct. So overall, I do feel that this dogma of not using tetracaine is driven by case series and case reports of topical anesthetic abuse as opposed to true appropriate use. And definitely larger studies are needed to prove evidence, but I think probably small volumes for a short period of times are truly okay. And it looks like many of you feel the same as well. Definitely, counseling is key, and I would say at least part of the dogma is true. Don't let the patient leave with a large tetracaine bottle and steal it from the ophtho room, because almost certainly they will run into issues. So I think this last case highlighted the importance of a good clinical exam and making sure that you don't miss any of those can't-miss diagnoses. So before we move into our next section, we'll just take a few brief moments and review some key features that you should double and triple check are not there on your exam before you write corneal abrasion in the bottom corner of your chart. The first one are the features associated with corneal laceration. So sometimes these can be very obvious, and other times it can be very subtle. So it's really important to keep a high index of suspicion, particularly in patients with a good story. So often that's going to be a patient who might have a high-speed mechanism of a foreign body to the eye. So in the middle image there, you can see the teardrop-shaped tubule, and you can also see the iris starting to herniate through the laceration at the 3 o'clock position. In the bottom, you see loss of depth of the anterior chamber. And so there's light reflection off of the iris, as well as the cornea and the right side, which is essentially touching each other. It shouldn't look like that. There should be a nice space, like we all know, representing fluid in the anterior chamber. And then lastly, cytosine is up in the front, so you can see fluorescein streaming down the front of the cornea. It's sort of being washed away by the leaking aqueous humor. And it's important to note that all of these or none of these may be present on exam. The cornea does have the ability to sort of seal up behind itself after laceration, and that might limit some of these findings. The next can't miss diagnosis, I think we all do very well. So we all look for infiltrates, I think. And it is possible to get a sterile infiltrate after corneal abrasion, and usually this is very small and in the periphery, less than a millimeter. But the truth of the matter is any infiltrate is one too many. So please provide these patients antibiotics and keep a particularly high index of suspicion in your contact lens wearer. And be sure to refer to ophtho. The last thoughts about corneal abrasion management that I will leave you with is that location really is key. Any defects involving the visual axis are important for a couple of reasons. First, the cornea is actually thinnest at the center of the visual axis, and it measures less than 0.5 millimeters there. Second is any defect that involves the stromal layer of the cornea, so the middle layer, if you dig back all the way to medical school, it can heal with scarring and opacity. So scars in the visual axis are bad and can limit patients' visual acuity long term. The other idea is that foreign bodies, unless you have a fear that it may have penetrated the entire thickness of the cornea, can easily be removed by us, and there's a number of means to do that. You don't just have to go straight for the burr. You can start by simple irrigation, moistening cotton tip, a bent 18-gauge needle tip. And I would say for the patients with retained rust rings, if anyone's ever removed one on the day of presentation versus 24 hours later, you will know that it is significantly easier to remove these after some time when the cornea softens up, and there's no harm to the patient. In fact, ophtho often does the same. All right, so moving into section 2. So hand trauma is a very common presentation in urgent care, and of all of the trauma, injuries to the distal phalanx are probably one of the most common. The simplest form of distal phalanx injury is probably a subungual hematoma, and for something so simple, there is an amazing variation in how we all manage these. So by another quick show of hands, how many people here who had a patient with a subungual hematoma greater than 25%, we'll say maybe it's about 30%, with no underlying distal phalanx fracture, would remove the nail plate to explore the underlying nail bed? No one. Okay. How about if there was also a distal phalanx fracture associated with that same hematoma? So 1, 2, shy hands going up. Okay. And if the subungual hematoma is larger, so we'll say it's about 60% and there's no associated distal phalanx fracture, how many people would remove the nail plate? And if there is a fracture associated with a subungual hematoma of that size, how many people remove the nail plate to explore the underlying nail bed? 1, 2, 3, 4, 5, maybe about 10%. Okay. Is anybody using tissue adhesives for nail bed repair? 1, 2, 3, 4, 5. Oh, good chunk. 15% maybe, 10%. And who's providing prophylactic antibiotics to open distal phalanx fractures or phalanx fractures that we have either opened with trephination or nail plate removal? 1, 2, 3, 4, 5, 6, 7. Hands are trickling up. We're unsure. Okay. All right. So we'll get back to these questions, but I think an important part of managing distal phalanx injuries is having a good understanding of the nail complex and the nail anatomy, which I don't think I really learned well prior to doing this presentation. So this is an image that's published by Patel in the Pediatric Journal of Emergency Care, and she just, I think, demonstrates the key aspects well. So first is the nail plate. It's just the nail. I don't know why we call it that in the literature, but it's keratinized structure, and it's made up of the cells sloughing off and apoptosis from the underlying nail bed, which is another word that you hear all the time in the literature, and it's confusing. So what is the nail bed? It's just the tissue that is underneath the nail, and it's made up of two important features. First is the germinal matrix, and second is the sterile matrix. So the germinal matrix is found more proximately. It actually starts just distal to where the extensor tendon inserts on the extensor tendon and extends all the way to the little white crescent under your nail called the lanula. And it's responsible for about 90% of nail growth. The sterile matrix lies just distal to that and goes all the way to the fingertip, and it's responsible for the additional 10% of nail growth. It also plays a really important role in nail adherence to the fingertip. The margins of the nail, so starting with the lateral nail folds or the perinechium, this plays an important role again in stability of the nail and attachment to the distal phalanx. And then you have the epinechium, your cuticle proximally, and the perinechium, which is basically where the sterile matrix meets the end of your fingertip and plays an important role in infection barriers. So in injuries that have the potential to disrupt the nail complex, there's a few key things in management you want to keep in mind. So first is you want to try to make sure that the sterile matrix is nice and flat to promote appropriate nail growth and to prevent long-term deformity. The second idea is that you want to make sure that the germinal matrix hasn't been particularly malaligned, we'll say. So in certain fracture patterns which we'll go through, it does have the potential to get sort of rolled up or even caught within fracture fragments. And then lastly, there is a school of thought that the epinechial fold should be stented open with either a nail plate or another sterile material to help prevent synechia from forming and issues with nail growth. Actually, the last thing that I'll leave you with is that we won't talk much about amputations today, but it's important to consider what remnant of the nail complex is left when you see an amputation, distal phalanx amputation patient, because if you have a little bit of germinal matrix there, it can actually lead to some problematic nail spikes, which can become chronically infected for patients and cause a significant amount of pain. All right. So as we've kind of alluded to in those questions, the management of subungual hematomas mainly the principles have been, depending on the size of the hematoma and depending on whether or not there's an associated phalanx fracture, determines whether or not we should remove the nail plate and explore the nail bed or simply trephinate. And frequently quoted numbers in the literature are a subungual hematoma greater than 50% will require nail plate removal or greater than 25% with an associated fracture. But where do those numbers come from? So probably the best quoted literature comes from Simon and Wolgen in 1987, actually. And they conducted a prospective observational study of 47 consecutive patients with subungual hematoma. And they took patients with subungual hematomas of any size. All of the patients had an x-ray, and all of the patients had their nail plate removed to explore the underlying nail bed. And what they found was that in 60% of the cases, patients who had a subungual hematoma greater than 50% had an associated laceration of the nail bed that required repair. And for them, that was a laceration that was at least 3 millimeters. What they found was that when they looked at patients who also had distal phalanx fractures, that number went up to about 95%. But the study didn't include any comparisons and also didn't provide any long-term follow-up for these patients. It sort of just ended there. So a number of people have looked at this and have thought, well, I'm not so sure that nail plate removal and exploration does much for my patient. And they've hypothesized that it just is associated with higher costs and is more labor-intensive. So Dean and al summarized this literature in 2012, and they didn't find any RCTs, but they did include 4 observational studies for an N of about 200. And in all 4 studies, patients with subungual hematomas of any size were included, as well as any patient with fracture, as long as it wasn't significantly displaced. All of the patients received trephination, and in one study, half of the patients received trephination, and the other half received nail plate removal and nail bed exploration. Important exclusions, though, whereas any patient with a lacerated nail fold, patients who had a significantly disrupted nail plate, so either it was also lacerated or wasn't at least partially adherent to the underlying nail bed, or patients with significantly displaced fractures were also excluded. So what they found was that there was absolutely no difference in complications or long-term nail deformities in any of the patients, and they were all followed for about 6 months to 2 years. In patients who had the nail plate removed and the nail bed explored, they actually had a higher rate of transient nail deformities, but none of them were long-term. The one study that compared trephination versus nail plate removal actually found a 4 times higher cost with the use of nail plate removal and also a significantly longer procedure. So I think it's safe to say that all hematomas, regardless of their size, can be trephined unless there is a significantly displaced fracture, unless there is a laceration to the lateral nail fold, and unless the nail plate isn't at least partially adherent and isn't so disrupted that it really doesn't do much. Okay. So what about the patients who have had the nail plate completely avulsed, or the patients that you just feel you couldn't get away with trephination because maybe they didn't meet our last criteria? Sorry. Better? Okay. How should we go about repairing the nail bed in these patients? So traditionally, we have been taught that they should be repaired with sort of meticulous reapproximation of the nail bed edges using an absorbable suture. It's a procedure that takes a considerable amount of time and attention to detail. But recently, studies have started to evaluate the use of tissue adhesives, like Dermabond, in nail bed laceration repair. Some of these studies have occurred in the pediatric population, but some evidence also exists in the adult literature as well. So Strauss et al. Completed an RCT in 2008 where they took 40 consecutive patients and randomized them to either receive Dermabond repair or nail bed exploration with suture repair. And they included patients with partial avulsions, complete avulsions, also patients who had hematomas that they felt couldn't get away with trephination. And they did also include patients with non-displaced tough fractures. The measured outcomes were cosmesis, as measured by a pre-validated score back from several decades ago by Zook et al. They also looked at patient reports of function, as well as time of procedure. And what they found was absolutely no difference in function or cosmesis, and the procedure was significantly shorter, so 9.5 minutes versus 27 minutes in the suture repair group. In this study, I will say that when you review the treatments, the group, pre-treatment, there certainly was a higher or more complicated injury pattern in the patients who ended up receiving suture, so it's something to keep in mind. But the study was also conducted in the pediatric population. It wasn't an RCT, it was an observational design, but they essentially took 30 consecutive patients with nail bed lacerations, and all of them received nail bed repair. So what that involved was basically close approximation of the nail bed edges, a single layer of Dermabond, and then the nail plate was placed back into the eponychial fold with Dermabond as well. And the extent of injury in these patients was significant. So some of them had lacerations all the way to the pulp, and more than half had undisplaced fractures as well. They followed the patients for a total of 3 months, and again, cosmetic outcomes as per pre-validated score, patient-related function outcomes were the same, and the procedure length was remarkably short at 7.5 minutes. So definitely small studies here, but tissue adhesives for nail bed repair may offer a safe and reliable alternative. The cosmetic outcomes and the complication rates seem to be comparable. Definitely, it's about 3 times shorter procedure length, but I think it's important in anything to consider the practices of your local experts. So I spoke to Dr. Murray Allen about this procedure, and he had heard of it, but he wasn't particularly fond. He had a fear that application of Dermabond to the eponychium would result in basically sticking down the eponychium to the underlying nail bed and preventing nail growth. But this actually has never been documented in the literature, and in 2016 there was another systematic review that was conducted, and it found an additional 4 studies to the ones we just talked about. They used only Dermabond to reapply the nail to the eponychial fold. They didn't actually repair the nail bed with it, but this has never actually been reported in any of those studies, and they concluded that Dermabond also was an adequate alternative to suture repair. He did ask me to put out a plea to the department while we were on this topic, though, and that is, if you are going to suture the nail bed, please do not use Vicryl. He finds that this is very hard for patients to tolerate, and he finds plain gut or chromic is a lot easier for them to deal with and follow at the plastics clinic. All right, so moving right along. So open distal phalanx fractures and prophylactic antibiotics. So distal phalanx fractures make up about 30% of all the hand injuries seen in the ED, and they make up about 67% of all the open hand fractures that we see. Now, we're taught that open fractures are at higher risk of infection and wound complications, and most of this evidence actually comes from literature looking at open fractures in long bones or at sites other than the hand. And there's a number of people that feel that the hand is at particularly low risk of infection because of its high vascularity, because of the ability to quickly obtain analgesia or do local blocks to provide debridement and wound irrigation. And then lastly, the mechanism of injury is often a crush or a clean incision. And generally, this leads to less periosteal stripping than the mechanism in some of the other long bone fractures. Sorry, I lost my groove a little bit there, guys. Just going to take a sip. All right. So a meta-analysis was published in 2016 in the Journal of Hand Surgery, evaluating the need for prophylactic antibiotics in distal phalanx fractures. And they included a total of 4 RCTs, or 353 fracture cases. And the studies ranged from 1987 all the way to 2008, and they took place in various parts of the world. Now, there was admittedly a lot of variation in the studies included in this systematic review. Not all of the studies looked at open distal phalanx fractures specifically. Some of them looked at all open fractures distal to the MCP. Overall, though, the authors concluded that there is absolutely no statistically increased risk of superficial infection in patients who received placebo over systemic antibiotics. There was no cases of osteomyelitis or deep infection. And they found this finding persisted even when the 2 studies with the highest quality review were included. At our own institution, Dr. Boyd and a couple of the plastics residents also did a review or an RCT in 2013, and it wasn't specifically looking at open distal phalanx fractures. It was at all hand trauma requiring surgical intervention, and they also found limited benefit from prophylactic antibiotic use in those cases, and that includes amputations that involve exposed bone. I will point out that some of the exclusion criteria vary across the studies included in this RCT. So the largest RCT actually excluded patients with peripheral vascular disease or diabetes. And at least one other RCT was conducted only in the pediatric population where peripheral vascular disease or long-standing uncontrolled diabetes is not all that common. So in speaking with Dr. Allen about the provision of antibiotics to these specific groups, he also felt that they would be of likely benefit to these patients, but he finds himself often reaching for the prescription pad in those cases, just for the reason that it's not as well supported in the literature. So something to consider. He actually felt that where we get into the most trouble with infection is not so much in omitting prophylactic antibiotics, but instead in closing wounds that shouldn't be closed in the first place. So he drew on the example of the crushed finger to the distal phalanx where the pulp is sort of extruded. And he's had several cases where we've tried to close those, often very soon after injury. And they just continue to swell, and you end up with a significant amount of necrosis and becomes a perfect sort of nidus for infection. Unfortunately, some of these patients have ended up with amputation as a result. So just some food for thought there. One other key feature that I'll point out from these studies is that all of them highly emphasize the need for copious wound irrigation and debridement. And only one study actually mentioned how much volume they were using, but they used a total of 500 cc's, so probably more than what most of us are using here. And when I spoke with some of the plastics residents, they didn't give me an exact number for open distal phalanx injuries, but they said in the cases of partial amputations where there's bony involvement, I think we all know Grayson, he's one of the well-known plastics residents, he's using at least 1 liter to irrigate. So being short on time and not doing an appropriate wound irrigation is not really a reason to be prescribing antibiotics. So, and I think any evidence that is proving safety and omission of antibiotics has really done a very good job of wound debridement and irrigation. So before we move on to our last section, I thought it'd be helpful to talk about a pattern of distal phalanx injury that is often quoted in the literature as being something that is under-recognized and mismanaged by ED physicians. Who doesn't like to hear about something else that somebody else has done wrong, right? Not to make the same mistake. So
This is an injury pattern that is at much higher risk of infection, and it may be the exception to not prescribing prophylactic antibiotics in open distal phalanx injuries. So most of the distal phalanx injuries that we see, whether they're tough fractures, longitudinal or vertical, they're going to be very stable, and they're often undisplaced. They can be splinted for a couple of weeks without sequelae. But some transverse distal phalanx fractures, especially those that are very proximal on the distal phalanx, have the potential to displace dorsally and herniate through the sterile matrix. And often the feature one we'll see with these is that the nail plate has sort of been avulsed out of the eponychial fold, and you can see it here just sort of sitting on top of the eponychium. And what happens in these cases is that the dermal matrix can actually get tucked up, or its fragments can actually even be stuck within the fracture fragments. So without proper anatomic reduction and freeing the fracture fragments of the tissue of the dermal matrix, patients can end up with chronic non-union, they can end up with chronic osteomyelitis, painful inclusion cysts, and permanent nail deformity. And a pattern of this injury also exists in the skeletally immature. So it's called the Seymour fracture in the pediatric patient, and it's a displaced distal phalanx fracture that also involves the growth plate and is associated with nail bed laceration. Clinically, these patients look like they have a mallet finger, so at rest they'll have this flex deformity. And mallet fingers are actually very rare in the pediatric population. Really what this flex position is coming from is the opposing forces of the flexor and extensor tendons across the fracture site. I think on the right-hand side you can see the flexor tendon inserts more distally, so it sort of results in that deformity. Oftentimes these patients will also have that sign of the nail plate being avulsed up from underneath the eponychial fold, and you can see it there on the left. So again, there's a lot of evidence emerging to show that this particular fracture pattern is at very high risk for infection and also at very high risk for complications, including growth plate arrest and shortened digit, chronic osteomyelitis. Those are sort of the main ones. So they often need surgical exploration to free the dermal matrix. K-wire pinning is also often required, and there's emerging evidence to show that early intervention and early antibiotics actually makes a difference for these patients as well. So definitely something that we don't want to miss. All right, hang in there, guys. We're in the home stretch here. So the last section is a common ED complaint that unfortunately many of us find very frustrating to manage. And I will tell you from first-hand experience that researching this topic is also very frustrating to go through because there's very limited evidence to help guide us. And you can't help but with wonder after reading the evidence that this is why we continue to struggle with it. So by quick show of hands, has anyone foregone topical vasoconstrictors for topical tranexamic acid? Whoa, a lot of you. Okay, awesome. Very good. And who is still using prophylactic antibiotics for anterior nasal packs? Okay, all right. So the basic approach to epistaxis, like anything in emergency medicine, starts with the ABCs. And a typical order of succession of management may look something like the following, starting with manual compression, blowing out the clots, trying your topical vasoconstrictors. If that fails, trying silver nitrate, cautery if you see a bleeder. Failing that, we're looking at packs, so starting with a unilateral anterior pack, then bilateral, moving to posterior packs and ENT and surgical intervention. But how can we optimize our success? And is there any evidence to support certain strategies over another? So starting with the topical vasoconstrictors, the medication that we often reach for first, is there any evidence to suggest that I should choose one over another in terms of efficacy or safety? So the short answer is no. The long answer is that the use of topical vasoconstrictors has never been studied in the management of primary epistaxis. So the closest one can find is actually an article from 2011 by Matu, who looked at rates of hemostasis achieved as well as rates of rebleeding in patients who got silver nitrate paired with one of manual compression for 10 minutes, xylometazoline, or epinephrine. And they did find that they were 3 times more likely to achieve hemostasis when vasoconstrictors were used, but there was no difference between the two employed vasoconstrictors. Many people have extrapolated from the literature, the operative literature, in studies that looked at epistaxis prevention in procedures like nasotracheal intubation or any kind of procedure that requires an endonasal approach. And what they have found is that xylometazoline is likely a reasonable first option because it offers as effective reduction in rates of epistaxis as cocaine, and perhaps even slightly better than lidocaine and epi. Studies also looking at the vasoconstrictive effects of the medication by nasal manometry or Doppler have found similar things. So I think when you see that, also paired with the scattering of cases in the literature of topical cocaine causing hypertensive crises or cardiac adverse events, I think xylometazoline is truly a really good first choice. I will just say that it doesn't offer any anesthesia to the patient, so if you are going to need silver nitrate or packing, you have to add another agent like lidocaine. So what about topical TXA? So it's still quite new in its available evidence, but one would argue that there's already more evidence for topical TXA over all of the vasoconstrictors combined. And I don't mean to poo-poo them because they've obviously been very helpful for us for many decades in managing epistaxis, but I just think that as more evidence emerges, just like we see in this room, it will be the first medication that we reach for. So the background for the use of topical TXA, so it's truly the injectable form but applied topically, it comes from a number of operative studies that looked at topical tranexamic acid and hemorrhage control. And the reason that they explored this was because of the theoretical increased risks of venothromboembolic disease, and also with the knowledge that with topical application, there's less than 10% of the systemic absorption that we see with systemic application. So in 2016, Cochrane published a review looking at 28 trials of various operative procedures, like arthroplasty, cardiac surgery, dental, spinal, ENT. And in these cases, TXA was administered in saline solution directly into the operative site or by mouthwash for some of the ENT cases. And what they concluded that was TXA decreased bleeding by about 1/3 compared to controls, and that persisted when only the highest quality studies were included. Now, there's definitely not this much evidence in the management of epistaxis specifically, but certainly evidence is continuing to emerge, and one of the most recent trials was actually just published a couple of weeks ago. Probably the best quoted in the literature, though, is a study by Zahid et al. In 2013, and they took a total of 224 patients with idiopathic epistaxis that failed to resolve after manual compression for 20 minutes, and they randomized them to receive either topical TXA or basically topical vasoconstrictor followed by an anterior nasal pack. So specifically what they did was they soaked a 15-centimeter cotton pledget in the TXA group and applied it to the affected nair. And in the comparator group, they received cotton soaked in lidocaine and epi for 10 minutes, followed by administration of an anterior nasal pack, which consisted of multiple pledgets soaked in tetracycline and packed, done as an anterior pack. And they looked at outcomes of bleeding at 10 minutes, recurrence of bleeding at 1 and 7 days, ED length of stay, and patient satisfaction. So 71% of patients in the TXA group achieved hemostasis at 10 minutes versus 31% in the anterior nasal pack group. 95% of the TXA patients were discharged in less than 2 hours versus 6.4% in the anterior nasal pack group. Patient satisfaction was also significantly higher in the TXA group, but rates of rebleeding were no difference between the two groups. The same group repeated a study just this month, actually. It was published, only this time they did it in patients who were on one or more antiplatelet agents. So they had a total of 124 patients in this case, and again randomized to the same groups. And their results were equally as impressive. So achievement of hemostasis at 10 minutes in TXA group was 73% versus 29% in the anterior nasal pack group. Rates of rebleeding at 1 day and 1 week were also statistically significant in this study. So at 1 week, it was 5 versus 21% in favor of TXA. Again, 97% of patients in the TXA group were discharged from ED at 2 hours versus only 13% in the anterior nasal pack group. And patient satisfaction was a 9 versus a 4 for TXA. Yeah. No. They apply it, and they basically would look at the pledget itself and at the back of the oropharynx to look for signs of bleeding. And that's correct. Out before they went. Yeah. So there are important considerations with this study. First of all, they excluded, and the other one, they excluded all patients who were on anticoagulants or were coagulopathic. So it's interesting to see, at least in the more recent one, the use in a patient population that typically gives us more of a challenge. I think the next step would be to use it in all comers and see how it benefits us in those patients that are particularly difficult. More importantly, though, I think it's... Yeah.
So in both those studies, did they just leave the budget in, or they actually did that anterior pack?
They just left the budget in. They removed it before the patients left the ED.
They actually did different things. You can't really say that if you put in the anterior pack, maybe the bleed was going to be aggravated.
Correct, and so I think that this is one of the limitations of the study is that the way that they checked rebleeding, but also the fact that they haven't used an anterior nasal pack that I think is comparable to North American standards. So I think that's somewhere where the literature needs to go. Like we don't pack the nose with multiple cotton pledges. We often use things like Miracell or Rhino Rocket. So definitely limitation, but I think some promising emerging evidence nonetheless, and I think a lot of people have found it very helpful here in the ED who've already started to employ it in their practice. Trying to go quickly through the last bit here. So the only other study published on this topic was actually quite a while ago in 1995. It was a negative trial for TXA, but I honestly feel that it had something to do with the way they applied it. So they simply injected a gel form of TXA into the nasal cavity of the patients versus a placebo gel. They provided no manual compression. They inserted nothing else into the nares of the patients. And what do you know? They had worse outcomes than standard treatment. Not sure that it adds anything else. So I do feel that it's a promising start. Definitely more studies required in sort of improving methodologic design and comparing it to North American standards of either packing or vasoconstrictor plus cautery. But I think there's very little harm in trying this, and personally I'm looking forward to using it on my next urgent care shift. So despite our best efforts with vasoconstrictors and topical TXA, our patient is still bleeding, and so we're forced to resort to packing. So there are 3 types of packs, but the literature has only ever compared basically dry hydrophilic packs versus gel-coated inflatable balloon packs. And there's just been a couple of small studies that looked at it in terms of patient-rated discomfort on insertion and removal, ease of administration for the person inserting it, and then rates of rebleeding on removal. So fairly consistently, patient reports of discomfort are considerably less with the inflatable balloon packs, and ease of insertion is also found to be greater in providers. There's definitely some inconsistent reports about rates of rebleeding on removal. Some studies, though, in patients after septoplasty who received anterior nasal packing, there was an improvement with the balloon inflatable packs, but that hasn't been the case in primary epistaxis. So last but not least, prophylactic antibiotics in anterior nasal packing. Do we need to do this? So you're noticing a little bit of a theme here, but I think in the era of progressive antimicrobial resistance, it's really important to consider these situations where we're quick to reach for the prescription pad. So this has been one of the traditional teaching in epistatic management. It's still present in Rosen's and Tintinelli's, although they both acknowledge the very limited evidence that supports this practice. The basis for the recommendation is to prevent complications related to Staph aureus or strep pyogenes, so things like otitis media, sinusitis, and the most feared complication would be toxic shock syndrome. There's actually never been a case of toxic shock syndrome after an anterior nasal pack for epistaxis, although there has been the rare case report of a patient developing toxic shock after an anterior nasal packing and sinus surgery. There exists only a very small group of prospective and retrospective observational studies in patients who have been admitted with epistaxis requiring anterior nasal packing. And to be quite honest, some of them are so small and their methodology is so interesting that I'm not sure that they offer much to us. The largest and the most sound is an observational study conducted by Pepper et al. In 2012, where 149 patients requiring anterior packing and admission for epistaxis received either antibiotic or placebo. So the first 78 received clavulin for 5 days, and the next 71 received placebo. All patients had an anterior pack in place for at least 36 hours, and there was no infectious complications in either group. Now, the only other study that I will chat with you guys about is actually a study that was done in patients in 1989 who got posterior packs and were randomized to receive either IV antibiotics or placebo. So there's only 20 patients, but all patients had posterior packs that were kept in place for 72 hours. And they monitored for outcomes of infection in both groups, and they also took swabs of the nasal cavities upon removal of the packs. Now, there was no complications of infection in either group, the placebo or the systemic antibiotic group, but when they swabbed their noses, what they found was heavy growth of multiple organisms in people on placebo versus moderate growth of a single organism on patients on the antibiotics. And I think in the era of antimicrobial resistance, seeing this kind of like almost like a selection out of a microorganism is just a really interesting finding, although of course it doesn't suggest causation, but just some food for thought. Brian Kahn is an emergency physician who published a best available evidence review in the Annals of Emergency Medicine in 2015, and I thought he summarized things well in the document when he said that although there's no compelling evidence to refute the utility of prophylactic antibiotics in anterior nasal packing, there's also no evidence that withholding antibiotics causes harm. His final recommendation is essentially to consider the omission of prophylactic antibiotics in any pack that will be removed within 48 hours, and to exert caution in those who are immune compromised. Our ENT practices here is that anybody with an anterior nasal pack should be getting prophylactic antibiotics, but of course most of these are being managed by ED physicians from start to finish. So I think if a lot of people are doing it, we should study it and prove it. So in summary, we've covered a lot of ground today. So starting with corneal abrasions, topical antibiotics, likely a little benefit outside of the contact lens wear. For pain management, I think NSAIDs and cycloplegics are out. Perhaps anesthetics are taking a role. And beware of those can't-miss diagnoses of laceration, ulceration, and defects involving the visual axis. In terms of distal phalanx injuries, I think for all subungual hematomas, we can trephinate unless they have a displaced fracture, a lacerated nail bed, or a completely disrupted nail plate. In your next nail bed laceration, consider trying glue. I don't think there's any role for prophylactic antibiotics for distal phalanx fractures unless the injury is grossly contaminated. And don't forget to check for that fracture pattern with the sublux nail plate, which is at high risk for complications and infections. Lastly, in epistaxis, I think first line for vasoconstrictor, probably xylometazoline. I think tropical TXA is probably worth a shot. Balloon inflatable packs may offer better patient comfort and ease of administration. And then lastly, somebody please conduct a study on prophylactic antibiotics in anterior nasal packs, since we are managing most of them from start to finish. So thanks, everybody, for your attention. A special thank you to Dr. Stella Yu, who kept me on track and is my supervisor for this presentation. Dr. Michael Connor and Dr. Murray Allen offered some expert opinion in some of the areas, and then Dr. David Gruber for suggesting some of the included topics.